My name is Shelby Allen. I've been a nurse for 8 years now. My specialty is cardiac.
So I'm Tessa Brock. I got into nursing straight out of high school.
My name's Megan. I got into healthcare. My mom is a nurse and my parents have both worked in healthcare since I was small.
So we have a few clips for you on medical shows. So we're gonna get started with the first one here.
I'm not getting a pulse. Code blue and ED alpha.
Love that he said that they yelled to code blue, didn't even see them feel for a pulse or anything. She just collapsed. There's normally, obviously we check for a pulse, and then if she has a pulse, then we'll start checking blood sugar and, try to figure out all the reasons this person might have collapsed.
What exactly is a code blue?
So code blue means that we have either have respiratory arrest or cardiac arrest. They're, calling for the crash cart because it has all the supplies that we need to run a code. So that means that we can intubate a patient. That means we can give medications. We can shock a patient if it is advised. But code blue means patient is either completely stopped breathing or they have lost a pulse or both.
I'm not getting a pulse.
Okay, right there. As soon as he felt there was no pulse, they should have started CPR at that moment. You feel for a pulse and you go for compressions.
Yes.
That's it. There's too many people around. You don't have to call for help. You don't have to pull out your phone. No. You've got 3 doctors right there. Mm-hmm. You should have started CPR. The other doctor could have called the rest of it.
Yes.
No pulse, no breathing. You should have started CPR.
Start compressions, you're running the code. I've never run a code. Do you want an amp bicarb? He's in charge.
One thing I really do appreciate about it is, the doctor, he took charge and he said, you're gonna run the code. Whenever we do have code, we do need to assign roles so that everybody had a clear role to know exactly what you're gonna be doing and who's gonna be making the calls. Because if you have that many doctors all yelling orders and whatnot to people, it can get really confusing and detrimental for the patient.
So when there's a code, usually we all have a job. Mm-hmm. So we run it like a code. So we all know ahead of time there's a recorder, there are about 5 jobs. So the person who's running the code will say call a code. You be the recorder. You're on meds. You're on compressions. You're on breath.
So if you will, before you start your shift, you already know what your position is if there's a code today. Megan might be assigned compressions. I might be assigned the recorder. This person is assigned to push meds. This person is assigned to comfort family in that time. You know when you start your shift what your role is.
Blue and ED alpha. Get out of here. Start compressions, you're running the code. I've never run a code.
It's way too chill.
Do you want an bicarb? He's in charge. Page anesthesia.
Pause. There's no argument. If that physician says amp a bicarb and he's fooling with his ACLS how-to, somebody, whoever is assigned to meds, is given that amp.
Because there's a cart that you pull up. So there's what's called a crash cart. So whenever somebody crashes or we have to perform CPR, they'll roll the cart over. The cart has all the meds, all the things that we need. Everything. It has the Ambu bag, which is for the respirations.
The IO, which is like the bone IV that goes into the bone. It has everything in it. So that nurse that's standing there looking side-eyed, he would have already been drawing it up. He wouldn't have cared that an experienced nurse is gonna be like, these are the steps of ACLS. I'm just waiting to hear it from the doctor to say give. And as soon as he heard give, he would have been pulling it up and giving it.
I might even already have it in my hand.
He would have had hands on the patient to access a site while he's doing compression.
So he's doing the wrong job.
Yeah, he's just side-eyeing, but that's fine.
Page anesthesia. What is the first question you ask in the code? Rhythm. What's rhythm? PEA. Should we shock? No, we can't. A rhythm's not shockable. Get me one of Epi.
When they say PEA, so a PEA is a pulseless electrical activity. So what happens whenever we have a PEA is you will see electrical activity on the EKG, which this one did not have anything on there, and they said, oh, PEA. So that means that whenever I see electrical activity going on, there's no pulse. And so that was a big misinformation there, just because it looked like she was in asystole, which in that case, like they said, no, you don't shock asystole, and then you would do epi. So epinephrine is a medication. It's adrenaline, essentially. You think of epi whenever we get like an EpiPen. So if you have a patient that has a severe allergic reaction, that is the medication that we use in that instance. It's another word for adrenaline.
What is the first question you ask in code? Rhythm. What's rhythm? PEA.
Stop. His hand should not have left that patient's chest. It would have said analyzing rhythm, and then he could leave the chest, but until it says that, you don't, and it's not even showing PA.
It's showing nothing.
It's showing asystole.
And also, those leads are probably on the floor. That's what it looks like.
I don't see enough leads on the patient to even get a rhythm, but so the wires that they put on the patches that connect to the wires that they put on your chest to get your heart rhythm, there, I see one, but that's TV.
I think that flat line is what is the most hilarious, though. She's flatlining, but it's PEA.
Yeah. When somebody flatlines, that's it. You can't shock them back. You would have to do compressions until you get some sort of rhythm back. An actual rhythm, VTAC, VFIB, usually are what you get back, and then it'll shock. When you put on an AED, it gives you instructions, continue doing compressions, clear the patient, analyzing rhythm. As soon as that rhythm analyzes, you're back on that chest, unless it advises a shock.
Should we shock?
No, we can't. A rhythm's not shockable. Get me one of epi. Make those compressions harder and faster. Prepare to intubate.
They had the crash cart, but it was on the side.
It's time to call the code.
No! This is my code. You gave me this code. She's 21 years old. Harder, man. You need to feel the ribs crack.
Okay, pause. Those compressions are weak sauce. Weak. That's just...
I mean, I have seen nurses straddle a patient to give compressions. I'm short, so a lot of times I either had to drop the bed or stand on my tiptoes and was like, somebody get me a stool, hop on the stool and do them, because you want to have the upper half of your body over the patient to throw your body weight into it.
We did have a student. We ran a simulation that was so much fun. And this student, she couldn't figure out how to get the bed down. Like, something wasn't working in the room. This student was like, I'm gonna get on the bed. And she got on the bed, straddled the patient, and was doing these compressions. Like, I thought she was gonna push the mannequin through the bed. And that's what we're looking for, not the little boop, boop.
Yeah, it's never a pretty sight. It's not pretty.
We're saving a life here.
And the hard thing is it really is up to the doctor to say when to stop. If they're new and they want to keep going because maybe this is the first patient that they ever lose, you might go a little longer than an experienced physician who is weighing risk and benefit in his head and is like, it's been 26 minutes. Yes, we may be able to bring her back, but she will never live a full life. And do we want the family to have to make that ethical decision, or do we make that for them? So there's a lot of ethics involved in codes and calling time of death and stop time and all of those things.
I'm not giving up.
I said that's enough.
We got a pulse.
You saved her life.
Her end tidal CO2 is less than 15 for the entire code.
That doesn't necessarily mean that...
Yes, it does. She's been without oxygen to her brain for 26 minutes. Congratulations, you got her heart beating again, but she's brain dead.
I think another hard thing to watch about that was just how disingenuous that other doctor was towards, the others in the code. it seems like he's a little desensitized. He's seen a lot of things. And that is something that can happen in our world, is that you get so used to seeing things that, you're just like, just call it already and then let's move on, because whenever we do code somebody and somebody does pass away, we have to go then move on straight to the next room. It can be this vicious cycle. At the end of the day too, he doesn't necessarily know she's brain dead. She most likely does have an anoxic brain injury because, like he said, she did go without oxygen for 26 minutes, but there's not just one mold that fits every single patient of how the outcomes were going to be. I just wish he would have been a little bit more, proud of him that he ran the code, he kept going, and he did get a pulse back. And then we make decisions from there. We try to see what's going on, slowly extubate the patient if we can, get the family on board. What do they want to do? Because at the end of the day, he owed it to save her life because she was young. She didn't have a do not resuscitate order, so he did his due diligence.
Currently, I'm the clinical coordinator in the nursing department, and I was at a clinical site, and we had a situation that was really hard for our students. So we've gone through our CPR education. They know about running codes. They know about kind of the basics of how it goes, but we had a student that experienced one in real life. So in real life, they're not as pretty and clean as, we make it out to be in the books. And we had a situation where we were running a code on a 78-year-old woman, and they called their child, who was the
TPOA?
Yeah. And the DPO said, no, save my mom. You need to save my mom. You need to save my mom. This code lasted for about 45 minutes. Mm-hmm. And by the end, my student was upset and was like, why are they doing this to her? This is unethical. This is horrible. The families kept telling them to continue. It took the doctor to have to step away and call their child and explain it. Mm-hmm. But it was this learning moment for the student where they were like, I thought that, when we say do everything, that means that I love my family member. And if we don't do everything, that we don't love them. But they had this moment where they were like, what, sometimes not doing everything for grandma might be best. And so you can't teach that through this type of experience.
I don't think people that are non-medical, non-healthcare understand the ramifications of what happens after the code,
because they make it look
we
like
have
this.
Cracked your chest and ribs. She's what they say 21. She may recover, she may be fine, she may be brain dead, stuck in the bed, whatever that is. Even if it would have been 2 minutes and they got her back, her chest is broken, her ribs are broken. She is going to have so many months of rehabilitation after this code that, is it worth it? So when you think about grandma who's 78 and we have just broke every bone in her upper body, there's a high level of pneumothorax or hemothorax that can happen, which means their lung collapse because you break the ribs, so the rib can puncture the lung. There's so many things that happen after this. Everybody thinks, oh, we coded them, they're back, everything's good. They get up and walk.
In these shows, they wake up and they're like, oh, I'm so
hungry. Like, they're in so much pain afterwards. Yes, they can breathe, maybe they can talk, maybe they're not brain dead, but there's so much recovery that happens afterwards. I always encourage my patients, once they're over a certain age, a DNR is best, because this is actually what's going to happen if I have to code you. And if you are okay with that, fine, sign full code. I'll do CPR all day long. But if you don't want to go through this recovery process, I suggest you sign a do not resuscitate. And I always tell people that does not mean do not treat. We will treat you up until the point that your heart stops and you have no respiration. At that point, we stop treating you, but we will give you all the medicine, all the interventions that we can. So I think sometimes TV shows give that false sense of reality where they're going to do CPR and they're coming right back to life just like they were yesterday. And that's not the case.
Oh, I love this show.
John, what's this?
It's a laryngoscope. No, second shelf from the top.
Hey, can you teach me how these work?
Some other time.
The paddles are definitely out of date. We don't use paddles anymore. We have patches that go directly on the patient, and so it has a monitor on it, so we can also monitor their rhythm while we're doing it, because again, there are certain rhythms that we do shock and don't shock.
My mom used to watch this all the time. Okay, pause. First of all, crash carts are checked at the beginning of every shift, and at the end of every code, they're restocked. A crash cart should never be this cluttered or messy. Everything has a place. The place is typically labeled. There's a sheet to say laryngoscope is there, everything's there. You check it. Before I even would take report, I'm like, okay, get your stuff done, but I'm gonna check my crash card off, because the moment you don't, something won't be there and there will be a code. Yeah. His symptoms aren't really realistic for what's...
We gotta stabilize him first.
Okay, also, we would never put oxygen on only. It would be the Ambu bag if we're getting ready to do
shock, CPR, anything. There would be an Ambu bag and it could have oxygen connected to it. I mean, there's been times that, you know, you shock patients to get them back into a normal rhythm. We call that cardioversion. Typically, they would have given med and put them under anesthesia because it's a jolt. It's like getting hit by lightning. So a lot of patients choose to go under anesthesia for that.
Carter, we need this crash cart and 4, body packer, pop the condom. Got it? Let's go. Give me some room, huh?
Here you go.
Stay here and try not to get in the way. Can't you cut him open and pull out the coke? We gotta stabilize him first.
Just having multifocal PVCs.
They talk about multifocal PVCs. So PVCs are a type of arrhythmia that we can have that if you continue to have PVCs over and over and over again, it turned into VTAC. Now in his instance, he went into VFIB, so I feel like it most likely probably would have gone into VTAC. Again, there's no mold for one specific patient.
Yeah, okay, lidocaine, 150 IV push. He's in fib, paddles.
Okay, that.
Also, she had paddles out before he called for them. They would have just moved her out of the way, I feel like. They would have told her, stand by that scale, touch nothing, observe.
Be a fly on the wall.
How would this have affected the other nurse being shocked?
It's just a jolt. They would have probably passed out and come back to.
Except for the head injury.
Yeah, that they hit their head. Really, we would be more concerned about the head injury than the shock. So like 200 joules. You probably pass out. Your body's going to reset. It'll be fine. But he probably hit his head on the way down. So we'd be more worried about having a brain bleed or some trauma to the head. It's like a high-powered taser.
But do we use those ones anymore?
No.
Are those the kind?
And it's not even...
I've never seen that.
She's shocked here and here. So it probably didn't go through the heart this way. Usually you'd shock here. You want to be somewhere either to give a diagonal or front and back, which is why we do the pads on kids front and back, so that it goes through the heart to shock it. So being here and here, it was probably more like a taser.
Okay, lidocaine, 150 IV push. He's in fib, paddles. What was that set on?
200.
Well, he should be okay.
So as far as him getting shocked by the paddles, that, I mean, obviously that didn't happen anymore because we used the pads, but I just think it's kind of funny. I don't know if he like got shocked in that instant, but it would have been best to hook him up to a monitor to make sure that we didn't put him into any arrhythmias, because when you shock somebody, it's kind of like being electrocuted, you know, you always have to make sure, you know, you're messing with the electricity of your heart, that he himself is not into any lethal rhythms.
What was that set on?
200.
Well, he should be okay. Thank you. Why don't you check on him, okay? Yeah. All right, clear.
It's about prioritizing your patient.
No, that's not good. Let's go again. 300? No.
Okay, pause. He should not be talking. Am I right?
I'm confused about his symptoms not matching up with what he's saying.
He's in cinema fib. Instead of AFib, he's in movie fib.
He wasn't even in AFib until right before they shocked him. Cardioversion is like getting kicked in the chest by a horse when they're trying to shock your heart back into a normal rhythm, which is why... It
wouldn't be like no. It'd
like
be
we would have probably gave lidocaine on one side, flushed it, little Versed, and then done the cardioversion. Maybe he's in some AFib instead of having just minuscule PVCs, because people live every day with PVCs, which is a premature ventricular contraction of your heart.
It just feels like you're getting like hit in the chest, but it's not anything.
It's not anything that's going to cause thrashing in the bed. I would think more of atrial fibrillation crisis, and maybe he's never had that before, so something's causing that, in which case they may cardiovert him in the bed, but they probably would have gave him a little Versed to calm his body down during that.
Thank you. Why don't you check on him, okay? Yeah. All right, clear.
Clear.
No, that's not good. Let's go again. 300? No, Claire. No.
He shocked him, and you could tell he was visibly like, no, don't do it again. So you always have to like look at your patient and do a pulse, and not with the one thing that as soon as he went into VFIB, you always have to check and see if the patient has a pulse. You know, you can't call a code necessarily until they don't have a pulse anymore. And so I feel like if he was like yelling, oh no, please don't do it again, he probably had a pulse. VFIB versus VTAC. So VFIB is ventricular fibrillation. What that means is the heart is just quivering. So it's still moving. So asystole, it is not beating at all. So we don't shock asystole because there's no electrical activity going on. So VFIB means that your ventricles, so you have your atriums on top, your ventricles are just quivering. So it is not pumping effectively to get the blood out to your body, just quivering. And we can shock that because you still have electrical activity going on. It's just not effective electrical activity. So we shock that and hope that your heart will start beating normally again. VTAC just means that your ventricles are still pumping, but your atria are not doing anything to help. So essentially your heart is not refilling with blood in order for it to pump out to the rest of the body. So essentially it just gets empty and it's just moving, but there is no blood pumping through your body to get to your vital organs, which is why you often don't have a pulse when you have that long of a VTAC, because there's none of that blood coursing through the body. And again, we can shock VTAC because there's electrical activity going on. It's just not effective electrical activity.
Are you doing that to her?
Oh.
Okay, someone call 911.
In his compressions, he's doing this.
He's doing the Heimlich on his chest. Like that's like a
Yeah, that's not a compression.
Stop. I don't think he's having a heart attack. But he looks so white and heavy. Yeah, but he's not heaving for air or making any noise. No air sounds on one side. The CPR must have broken a rib, which collapsed his lung. It's a pneumothorax.
Yeah, when we do CPR, we do oftentimes break ribs because you have to be able to push hard enough to get down to the heart to basically essentially artificially beat the heart for them. And in this case, he was a larger man, so it probably took just a little bit more force to do so. It was hard to watch as far as him judging and saying that, oh, you broke his ribs, so it probably punctured a rib, so now he's got a collapsed lung. Well, the only way we can actually confirm that is by x-ray. You know, we need an x-ray to see exactly what is going on. So this potentially could have been dangerous if that is not the situation that he was in, if he didn't have a pneumothorax. And so a pneumothorax is basically a collapsed lung like they were talking about.
Stop. I don't think he's having a heart attack. But he looks so white and heavy. Yeah, but he's not heaving for air or making any noise.
And heavy. What does heavy have to do? I don't understand that. He's breathing.
No air sounds on one side. The CPR must have broken a rib, which collapsed his lung. It's a pneumothorax.
So what made him go down initially? Was it a choking incident? He didn't just have he just said it's a pneumo from compressions.
Well, he wasn't doing compressions right enough to get a pneumo. I will tell you that. So this is confusing all around.
Yes.
But let's just say his lung collapsed.
Yeah.
And that's why he went down. Okay. And then you have no way to tell where, in what part of the lung, you know, like is it the whole lung? Is it a partial pneumo?
Is that where you would even put the needle?
No.
Hey, I don't know.
That's why when he did that, I said, it's here, it's in the rib. But that's not long enough to do anything. That's a half, 3/4 of an inch needle.
Look at it, it's the size
You're not
of
even
his
getting
nipple.
through his fat tissue.
No.
On a man that big?
No.
You're not even getting through his fat tissue.
Would a needle that size work on like a small guy like me, or
No.
does it be bigger?
It needs to be bigger.
Okay.
And he's over his heart. I mean, you're closer to the heart than you are the lung.
I mean, let's see. That's his nipples here. We're not. Here.
But you still wouldn't get to the heart because your sternum is right here.
You're trying to fix a pneumo up here, I think.
Your sternum, though. You're in the sternum. There's a bone. It's this thick.
Yeah.
You can't get that needle through there. That needle's not tough enough. That thing's gonna bend.
No rush of air. He's still not breathing. Maybe I was
It's
right.
on his sternum.
No. The needle is long enough to reach his pleural cavity.
And I'm glad you figured that out.
But this might be. Huh.
Is that-
a pen from my golf club. Would you grab me that martini glass?
This one's almost so bad that there's like, you like can't even comment on it because it's so bad. He didn't even check for a pulse, did he?
We didn't check anything.
We're just stabbing.
We're just putting things places and hope that they work.
They work. Like we didn't have any, nothing.
Good.
And then what are we giving? Like lidocaine?
I thought it was the martini that he was injecting. I was like, wait a second.
I'm gonna say it's lidocaine to numb the area, but
Who drew
honestly,
it up?
if
Where'd
he's
it come
unconscious, who cares?
Yeah.
Hopefully the painful stimuli wakes him up.
Yeah.
Good.
And if he's down with a pneumo, you're taking too long because he would be in a high level of distress.
And he would also be blue.
Blue.
He would be so blue.
He would be like more than panting.
And he's not
like
gasping enough. Yeah, it's not.
Yeah,
He's just like,
Good. Okay.
I still feel like he's too high.
yeah, he's in the armpit.
And that's not even sharp enough to puncture, what's it called? Like that thick muscle membrane that's right there. I don't know if you've ever had like the steak with a piece of gristle that you can't like cut through. That's what it's like. So that dull, that dull end of the pen is not puncturing through that.
He put a scalpel through it.
Oh, did he?
He just happened to have, I hope it's not an X-Acto knife, but it looks like that.
Oh, maybe. Okay, let's see. Let's see what it is.
Good. Good. Okay. Thank you.
Yeah, none of that was sterile. He most likely is going to end up with some kind of infection if that were to happen. I know he rinsed it off with vodka, but and vodka is basically rubbing alcohol. The skin wasn't clean, and none of that was going on.
It's a scalpel. I don't know. It looks like it. I don't. That's his
Oh,
scalpel.
that's an
X-Acto knife that he's using as a scalpel.
It's very clean.
Okay. Thank you.
This man is going to be set. Okay, so he cut him open. He cleaned his pen. His stainless
He's
steel
checking
pen.
the boxes. He's just doing it wrong.
Yeah, that's not going through there like that.
No.
There's no way.
So what does septic mean?
He's going to have a massive infection.
And none of that was clean. That martini, not.
She had already drank out
There
of
were
it,
olives
and
in
it's
it.
mixed with other stuff. So it's not like straight 100 proof alcohol.
Some Sprite,
There's
sugar going in
spit,
there.
lipstick.
Ew.
Who knows? It's like vermouth and
Why
gin.
didn't he ask for like vodka, whiskey, bourbon?
You're sitting right by the bar.
Yeah, like someone give me
100
some
proof,
vodka.
sealed bottle, dump it on there.
No, we want the martini for the looks. He's like,
Rush of air. Okay, the lung is re-expanded. Sir, we're gonna get you to the hospital, but you'll be okay.
The other thing that kind of cracked me up was that, as soon as you get, gush of air, the lungs reinflated. Again, you have to confirm that by x-ray. That is not something that usually is instantaneously. They are put on a chest tube to continue to help drawing that air out, because when a lung collapses, you have a big pressure of air that doesn't allow that lung to reinflate. So that's why they're talking about how the rib punctured that pleural cavity. So then you have that pressure going in there, and so it collapsed that lung. And so it takes time for, you put a chest tube in and it helps draw out that air and that pressure, so that way that lung can reinflate. I certainly have never been in a situation where that happened instantaneously. The patient might have relief pretty instantaneously as far as being able to maybe breathe a little bit better. But yeah, it's definitely going to take probably a little bit more time than that to reinflate. And again, don't ever do this in public. Just call 911, no matter who you are.
All right, what do we got here?
Ready?
okay, you can pause. So in the ER, generally our first thing is that we provide privacy. So I know that's not great for like cameras and for the movies, but usually we would be in a room or a curtain pulled, yeah. Curtain pulling isn't as common. They will use an actual physical room first so that you can shut the door and have for the privacy, but
for the sake of their triage, a curtain would have been pulled.
We're gonna have to stitch you up. We're also gonna need the serum tox with an alcohol level.
Yep. We were not drinking.
That's why it reeks like beer in here. What's your name?
Well, what's yours? Did you want to have dinner with me sometime? Or?
His name's Brett. He got hit in the head with a lacrosse stick.
All right, Brett. Follow my finger. So you guys like to play lacrosse at night? Open your mouth.
No, it's actually pledge week, so we... Wait, dude, that's not gonna hurt my chances, right?
Dude, shut up. I took a vow.
You took a head wound to get into a frat?
I'm already in. I just got a backspring by accident.
I definitely would have taken that hit if it meant I'd get in.
You geniuses do realize that even a minor head wound can be dangerous, especially when combined with drugs and or alcohol.
I told you.
Okay, you can pause
They weren't
it.
drinking.
So I feel like she mommed him hard, and I think that was okay. Are you good with that?
I am that nurse, so yeah.
I would say that's very appropriate.
We're a holistic frat. No booze, no drugs. We even meditate.
Well, you seem very enlightened. I'll be back. All right, field trip's over. If you vomit, come back. If you're dizzy, come back. No alcohol. And no sports. You
Pause. So I feel like she looked at him and his appearance completely changed from her initial contact with this one.
Oh boy, yeah.
Yes. Like now his eyes he has dark circles around his eyes. They're sunken in. He looks a little clammy. I feel like I probably would have turned my attention to him and said, "Are you feeling okay?"
He suddenly has a 5 o'clock shadow also.
Well, yeah, like I'm like his whole appearance
Looks different.
completely changed. And as a nurse, like you pick up on those things when you're in the room with families. You're you're starting to look a little pale. Are you feeling okay? Do you need some water? So I feel like in a real life situation, she would have picked up on that at that point when she was walking back in the room and he is looking completely wrong.
You think you can help him stick to that? Ethan, you with me, buddy? Ethan?
Ethan, you okay?
What do you take, Brett?
Ow!
I need help over here! Doesn't have a pulse. We have to get him to trauma. 3, 1, 2, 3.
Okay, so we would never, ever be like, oh, hey, we're doing compressions, but let's go take him to a new room.
Let's do 5 and throw him on a cart.
Yeah.
Yeah.
Unless we're going to like surgery, but that's not what's happening.
What's the thing called that they have now? The big, and it gives the compressions.
Oh, yes.
What's it called?
I don't know. I can't remember.
The Compressionator 3000.
Yes.
I can't think of the name of it, but it's a ginormous machine, like as big as a mini fridge, and they put it on patients now to give the
They've made
compressions.
it smaller now.
Yeah.
They've even smaller versions. EMS has them. Yeah. And they auto compress the person.
You can put that on them and it gives the compressions while you're trying to get them all together. But we would have never picked a patient up that high and put him on the bed. There would have been like a backboard slid underneath him and then a pull, the bed's being all the way low, and then you kind of slip them over and you continue.
I mean, we would
compression.
have had to have a backboard underneath there because that's a bed, right? Well,
yeah, well, because those are like the OR beds, so they really don't have like the where you can pull for CPR thing. You have to throw a backboard underneath it.
What did he take, Brett?
I don't know, I swear.
We have a cardiac arrest! Claire, call out water.
okay, you can pause. Those compressions are what we were looking for on the last one.
Yes, those are good.
Those are good ones.
That is a mannequin at this
Yes,
point. The way his chest is compressing, that is a mannequin.
Trauma. We need Atwater. We need LeBlanc. We need a talk stream, but only on the injured one. Let's get a line going. So Shelby, let me know when you got to read. Pulse check. He's in VFIB. We need to defibrillate. VFIB, 200 joules. Brett, what did he take? Sergeant, pads on. Ready. Everyone clear? Resume compressions.
You can pause. Okay, this one is way better than the other.
Yeah, this is actually a pretty decent code.
Yeah.
For TV.
Each person has their own job. They're doing their thing. I mean, They even rotated compressors, right?
They tried to. He was in his zone.
That's right. Yeah. This one's way better than the others. There must be a doctor on staff or nurse.
Brett, what did he take?
It wasn't dangerous.
One Aunt Beppy. Whatever it was, he did it to impress you, all right? So if you don't tell us now, Ethan's gonna die.
Soy sauce. He drank soy sauce. You make all the new pledges, dude. If
Okay,
they don't,
pause.
They get the...
I just have a comment that even though things seem harmless,
Yes.
everything in excess can be bad for you. You know, we think about excess sugar causes diabetes, but we don't think about like salt and potassium.
Or even water.
Even water. You can have water toxicity. Like you can, especially if you're dehydrated and you chug water, your body will get water toxicity.
There was a frat boy that died from, they made him drink like a full thing of water. It was like multiple gallons in a short period of time and he died.
You just waterlog yourself and die. So it's important not to understand what you're doing in order to keep yourself safe, number one. And you think about that sodium is salt, right? And so if you put so much salt in your body, it's going to dehydrate you because there's going to be more salt on the outside of your cells than the inside. And you think of osmosis, your water is going to move towards that salt in order to dilute it and make everything equal. So it is pulling the water from all of his organs and all of his cells and essentially dehydrating him to the point that he passes out, to the point that it messes up his electrical activity, because all of those minerals are needed to keep your electrical activity working properly. And he had said, oh yeah, we were drinking alcohol, we were drinking soy sauce, they could have started him on a saline drip or D5 or some kind of drip to equal those out before he passed out. When I did intakes, like when I worked pre-op, I would ask people, do you do drugs? Cocaine, marijuana, ecstasy. And some people would just kind of look at me and I'm like, I don't care what you take. I just need to know what you've taken because it will mess with your anesthesia. And so then they'd be like, oh, I smoke marijuana. Okay, when's the last time you smoked? Yesterday, today, this morning, when? Yes, last night. Okay, great. We just have to know because all drugs interact in a certain way. And I think people are scared to tell their healthcare providers things like we're gonna call the police. Honestly, I just tell them, hey, I don't care what you do in your free time, but I gotta know so that I can give you the appropriate treatment. And so a lot of people would ask, are you a drug user? And I would just say, have you used any cocaine, marijuana, or ecstasy or methamphetamine in the last 72 hours? And I started getting better responses by just asking that way than asking, have you used any drugs?
That feels shameful.
So the way that you ask questions is important too, because in the beginning, if she would have said, well, what else? Kind of like, so tell me more about what you guys, or your initiation process.
Those are my famous words.
Yeah,
Can you tell me more about
that?
that?
The tell me more. But making people feel comfortable in divulging their information is, if she would have shown just a little bit of interest outside of her judgment, she probably would have gotten more information to that. Yeah, we were drinking alcohol. We also, they were kind of laughing jokey. We also make them drink a bottle of soy sauce. It probably would have triggered her to say, okay, alcohol is dehydrating, soy sauce is dehydrating. How much soy sauce did you drink? And put in an intervention so that this didn't happen.
She would have been more of a person. And that's what I think can be kind of hard. And then what I try to teach the students is like, you have to stay curious. It is so important that you stay curious, because the moment you flip over into judging, that's when you are rude, you are not kind, and you also don't get good information, like with the drugs and alcohol. Whenever I ask, I'm like, okay, tell me more about why you did that, or what else is in it, or how, you just ask the questions, they'll tell you more. Like if she would have been more friendly to them and said like, okay, so you guys drank alcohol and you use these lacrosse sticks to hit each other, like, can you tell me more about what happened tonight? Like, how did you end up here? They'd probably say something like, yeah, we took soy sauce shots and then we did this, 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 and this. And then I'd say, oh, okay, we need to do some work here with our fluid electrolyte balances.
So everything sends off triggers in our brains. like, oh, that connects here, here, and here. Maybe you need to get checked out too. They probably would have done a metabolic panel and saw that his sodium was through the roof.
I mean, if we found out that someone drank an entire bottle of hot sauce, soy sauce, any of that stuff, we'd be like, okay, you're now a patient.
Hey, Cicely.
Does anyone have any other suggestions on how to save this patient?
Time, Dr. Curtis.
Time of death, 4:17 a.m.
What?
That's a real thing that does happen, because when you're in the moment, sometimes you skip over things that could help. I mean, your mind goes 1,000 miles a minute. And so you're like, do this, do that, do this, do that, do this, do that. I mean, even now, like when we're at clinical, there's times that Megan's like, oh, you should have, I'm like telling her what happened. She's like, oh, you should have had him do X, Y, and Z. And I'm like, I didn't even think about that. You know, so different perspectives in healthcare can make a big difference. That's why a lot of people get second and third opinions, because even if you have two doctors that specialize in the same thing, perspective is everything. And sometimes what your patient tells one doctor is not the same, or they add more to it than what they tell somebody else. So I'm always like, talk to the people on the healthcare team, because then you paint a full picture. Ask the same question 3 different ways, and I promise you'll get 3 different answers, and you'll have more and more and more information.
Yeah, I really like that. I work in labor and delivery, and so with babies, that doesn't happen. But I feel like if I were to evaluate a code, that would be a really cool thing, that if the provider would say something like that, because what if we had like cardiac tamponade, which would be the heart filling up with blood? Well, one of the answers to that is to aspirate the blood from around the heart. So maybe, I think that's not the situation.
So I have a psych background, so when we would put overly aggressive and combative patients in isolation, once they come out of isolation, you have to have a debrief, not only with the staff, but with the patient as well. And you kind of say that, what could have been done differently? What things can we provide you to help you cope with however you're feeling or whatever is going on? Now, some of the patients, they're just like, nothing, no one, I hate everyone. And sometimes they're like, well, what really triggered me was she kept trying to make me wear a blue shirt today, and I don't want to wear the blue shirt, and nobody was listening to me. And that's how I felt in that moment. Even though they may have given 7 options, all of them were blue, and that just wasn't. I mean, sometimes it's something very little.
It's not possible, yeah.
Yeah, and sometimes it's something that is possible, and you can make those changes. So debriefing after every situation, if you will, that occurs. I mean, there's a lot of times anywhere I've worked, and I'm like, what could I have done? Like, what could I have changed? In that moment, I didn't know. I thought I did everything I could. And then, so again, that's where perspective is everything.
Did you actually just page me to find out how much Tylenol to give to Mrs. Lenzner?
I was worried that it could exacerbate the patient's...
It's regular strength Tylenol. Here's what you do. Get her to open her mouth, take a handful, and throw it at her. Whatever sticks, that's the correct dosage. And under no circumstances are you to compromise our no talking agreement.
Yeah, I have definitely been talked down to by a doctor having a call about Tylenol. But what people don't understand that is if I order Tylenol on my own thing, I am practicing outside of my scope of practice because I am prescribing medication in a hospital setting. Yeah, sometimes I have to call and say, hey, I just need Tylenol because my patient has a headache. And there are some doctors that are like, are you freaking kidding me? And I'm trying not to get in trouble and practice outside of my scope of practice because, you know, that's my license on the line. People just think, oh, it's just Tylenol. But then, you know, the doctors are also supposed to kind of do a little bit more critical thinking as well as we are as nurses. And, you know, if I have a patient that's in liver failure, you know, I'm not going to want to give them Tylenol. And so sometimes, you know, we just have to help each other out and whatnot. Some hospitals have what we call standing orders. So if it's something like that for Tylenol, it says, okay, hey, if their liver labs are within, you know, normal range, they can have regular strength Tylenol to treat, you know, headaches or whatnot, or a fever. And hospitals and doctors nowadays too put on what we call PRN orders, so as needed orders. And Tylenol usually falls under that. And they'll have like stipulations for pain levels or what the pain is for, because if a doctor says, okay, this is for fevers, but my patient's complaining of a headache, I also have to be careful and I have to clarify that order, and I have to get that clarified under indications and put headache under there. Because again, if I give Tylenol for a headache, but it's only indicated for fever, I'm acting outside of my scope of practice, so.
Did you actually just page me to find out how much Tylenol to give to Mrs. Lentner?
Oh, this is real
I was
life.
worried that it could exacerbate the patient's...
It's regular strength Tylenol. Here's what you do. Get her to open her mouth, take a handful, and throw it at her. Whatever sticks, that's the correct dosage. And under no circumstances are you to compromise our no talking agreement.
I know a doctor just like that.
Same. I've had a doctor be like, call me when you actually know something. Click. I'm like, okay, thanks. Yes. You know what? We try to teach our students too. Like, they all consume this type of media. They know about the mean doctor. And I'm like, in the classroom, like, if you don't know what you're going to call them about, they will be mean to you, because some of them are people. Like, they get irritated and frustrated when somebody calls at 2 a.m. over Tylenol, until they have that first phone call where they say, like, how much Tylenol do I give? And the doctor says, you should be smart enough to figure it out.
There are things in every healthcare setting called standing orders. Tylenol is included in every set of standing orders I have ever encountered. And if you have a Tylenol order and it's not clear, just use your standing order and then say, hey, I gave this much Tylenol initiated by the standing order.
Yeah.
Those things actually do happen.
Yeah.
Just like that.
I think every unit's a little bit different, but overall, we're all people and doctors are people. And, you know, I'm sure I've been rude at times, but I've definitely been on the receiving end of that type of rudeness.
I have, but it only happened one time, so.
Mine's happened more than once.
Last bolts en route, 4 minutes. Car crashed into a construction truck. Post came through the windshield.
On my count, 1, 2, 3.
Alter, VP 70 over 30, dislocated left hip.
Ross, take over compressions.
Holy crap, this is Drake Finn. I got it.
I said Ross, Dr. Avila, you are not a character in his movie. This is real life. Let's go.
Ready, pulse, full extremities to your shock.
I think that gives a good example of like how chaotic things can get when you see how many people are just going and yelling and this and that. And you know, I never worked ER or trauma and whatnot, and so I don't necessarily know a lot about that. But one thing I will say is I'm very surprised that the guy was not intubated en route or and whatnot. They intubated as soon as he got to the hospital. I mean, usually if they code on the way, but again, I'm not an EMT or a flight nurse, so I'm not sure exactly what happened there.
We need to activate the massive transfusion protocol.
Already did that from dispatch. Sonia, is there anyone you want us to call?
Oh God, why? Is he dead?
No, we're working on him.
Call my daughter, please. Her name is Delia.
Look out, coming in.
All right, nurse, he's been down 6 minutes. Need epi and blood. My phone's in my purse. Call Andrew Ferryman. He needs to be here too.
His agent, seriously? Go make the call.
Okay, left leg is shortened and rotated internally. Okay, you've got a dislocated hip and we're gonna have to put it back in, all right? So I'm gonna get you some meds.
Drake!
Somebody give me the bullet on Mr. Finn. Got a call from the board.
Rocks, this is the driver. We've got a pipe that came through the windshield and impaled him. Vitals are unstable. Lost pulses en route.
Page Dr. Layton. Tell him to have an OR ready. I need an ultrasound over here now.
What did the board have to say?
Don't let him die.
Drake, honey, talk to me.
Okay, this is gonna be painful, but it's gonna be fast.
Just do it.
3, 2, 1.
I've seen doctors reset bones in ER, and it is quite that disgusting too. That's one thing I can't do it. It makes it like makes me cringe. And there's some things that even as a nurse that I'm like, can't stand. I can do blood, gut, gore, all that stuff, but trying to put a bone back in place, it gets me.
Okay, pulse is good. Get her off the board. All right. Whoa. Let me get some tape over.
We got a fractured arm.
Right away.
We'll splint it later, all right?
Okay.
Okay, pulse, he's back. Good job.
Ready?
He's weak. Are you ready to move him?
Stop. Impalement is millimeters from the aorta. Could sever any moment. One wrong bump to the gurney and he is gone.
And this is just my own opinion, that I thought was kind of funny that, you know, he said, stop, nobody, one wrong bump, and you know, this aorta is gonna blow, but he just went on a full-blown helicopter ride. So, I mean, if it was gonna happen, it was probably gonna happen in there, getting on and off and whatnot.
Fall. Axial load injury after his window washing platform gave out. GCS 3, BP 70 over palp, heart rate 135.
All right, that long fall, we're looking at injuries to the brain, spine, chest, and abdomen, let alone long bone fractures. Maggie, I need extra hands and an OR on alert.
Done.
What's he got for IV access?
16 gauge on both arms.
All right, very gently.
Yeah, I was very impressed that they were able to get 16 gauges, let alone in both arms. So the gauges work for IVs, that the smaller the number is, the bigger the needle is. Having a 16 gauge is normally used just in trauma emergency situations. At the bedside, I'll use 18, 20, or 22. For the most part, I was surprised because it seems like he is obviously bleeding, and I know they mentioned that he's bleeding into his cavity, his abdominal cavity, and so he is clearly going to be volume deficit. And so, you know, when you're losing a lot of blood, you lose the volume, which means your veins are smaller, so it's going to be a lot harder to get a 16 gauge in. So, I mean, cover me impressed with that. But normally I have seen in situations where they'll use what's called an IO or an intraosseous type IV, so where they drill an IV catheter into, usually they usually will use the shin, but in his instance he does have quite a few injuries on, like you said, like all the long bones. It seems like that could be why they didn't get anything in, but let alone, I mean, I would have been happy with a 22 in that instance, which is a smaller one. So I was just very impressed that they got such big IVs in both arms when he had already lost a lot of volume. So,
Buddy, on my count, 1, 2, 3.
Good luck.
Thanks. All right, likely cavitary bleeding. Wheeler, get a groin line. Start the MTP, hang 2 units of O-neg on the rapid transfuser until we type and cross X-ray. I need chest, pelvis, and C-spine. And let's get the ultrasound over here to fast his belly.
Lungs are clear.
All right.
I'm gonna start the groin line.
Help me reduce this.
So several things there. Like you said, the lungs were clear. I'm very shocked that his lungs were clear, considering all of the, you know, bone injuries that he had from this fall. I did like that they mentioned, you know, we're going to do O-negative blood for this patient until we type and cross him. So type and cross just means that we get the patient's blood type, essentially. O-negative is a very universal blood type, so everybody can have it, usually without any reactions. And then they mentioned on the rapid infuser, which just means that we're going to be just pushing blood to try to keep his volume stabilized while he is continuously bleeding out.
Big fracture. Come on. 1, 2, 3. X-ray. All right, step back. Pelvis down, C-spine.
On the box.
Chest X-ray is up.
Tension hemopneumothorax, trachea shift.
First of all, the groin line, we normally make that a very sterile procedure because you're going into a big vein in there, and most likely they were going to make an arterial line. I don't know what their purpose was, so they didn't clarify whether it was going to be a venous access or an arterial access. That could be 2 different things, but regardless, that is a sterile procedure if we're going to do a line like that. But as you can see, they pulled up the X-ray and mentioned that he has a tension pneumothorax. So what that means is that he has a collapsed lung, and the pressure from that collapsed lung is causing so much force that it is moving the trachea, and that's what we call a tension pneumothorax. The doctor previously had said, oh, he has clear lungs, his lungs sound clear. Well, if you have a tension pneumothorax, that one side is there's going to be no air movement on that one side. That does not correlate together whatsoever. So.
Venous returns down. Give me a chest tube. Show me the pelvis.
Got it.
Vertical shear of the left hemipelvis. It needs traction. Pull up the C-spine.
Up.
Multiple C-spine fractures. Wheeler, how's that groin line?
So then the other thing that he mentioned was, he said it was a tension pneumothorax. So pneumo just means that it's air that's pushing there, but whenever he went and tried to put a chest tube in, you saw that huge gush of blood, and that's what we would call a hemothorax. So meaning that that cavity has been filled up with blood, creating all that pressure. And again, that can still cause the same effect of, you know, pushing everything, but it's a hemothorax in that case. So we would try to get all that blood out, again, put the chest tube like he's trying to do, which is correct. Yeah, they are two different things, and the chest tube and the setting that we use for the chest tube would be different in that instance. So
done.
All right, chest tube's in 2. Let's move. Justin didn't survive a 330-foot fall just to die in my trauma bay. Let's go, let's go.
Witnesses report that Mr. Pepper clung to his window washing platform as it fell, almost riding it like a surfboard. Physicists surmise this likely created wind resistance that not only slowed his plummet, but also absorbed some of the force from impact. That might explain how he survived such a horrific fall.
Yeah, I think that makes a little bit more sense as far as, somebody just free falls from a 34th floor, I think is what they said, most likely wouldn't live. The physics of it make a little bit more sense of why maybe it wasn't as hard of an impact as it initially would have been had he not been on the window washing platform.
Dysentery bleeders are tied off. Let's resect the bowel quickly and move on. GIA 80 stapler with a reload.
50% of people who fall 4 to 5 stories die. 10 or 11, it's almost 100%, so this is a first.
There's an exception to every rule.
So they mentioned there's an exception to every rule, which I definitely don't disagree with, because what happens to one patient might kill one patient, but then the other patient might be completely different. Things affect everybody differently. What I can take may not be what the next person can take as well. Or if I have a full-blown stroke, I might have, full disabilities rather than the next patient. It just really does depend on what's going on with the patient, the environment, the care that you get as well. The doctor that you come into, the hospital that you go to. You think about rural communities, don't always have quick access to certain things. So, there are so many factors that play into a patient's outcomes. So.
33 stories, God. Massive subdural hemorrhage. Significant left shift. Big mass effect is crushing his brain inside of his skull.
Well, he did fall off a building.
Craniotomy, right?
To what end? He's coagulopathic. I go in and take out the clot, it'll just reaccumulate.
No, I don't think so. I'm actively giving him plasma platelets and cryo.
Which improve his overall chances of survival from 1% to 2%. I'm not opening up his skull. I question whether he's even strong enough for the CT, but that was your call.
If the pressure in his brain isn't relieved, it's over. That's 100%. I got him this far. He'll get through surgery.
All the king's horses and all the king's men. Guess I should have gone to you.
Normally when we hear about a shift in the brain that essentially creates the patient to be what we call brain dead, we look at their pupils in that instance. And so what I would have liked to know in that instance were his pupils what we call blown, so they have no reaction, and then you just see them, they take up like the entire, like the black part of it. That would have been a good thing to know, because once you have a pupil blown, that's the end, and that most likely I would imagine that is what's going on, because if he has such a shift. So I definitely side with the brain surgeon on that side, just because you have to look at risk versus benefit. I understand that it's going to be an emergency to try to undo the pressure on the brain like that, like you said, to what end, is it really going to be something that helps them if we're already this far? But also some doctors don't want to take liability if they have to look at cases as well, and is this something that is feasible that I can do, that I'm willing to put on my back? Because if that patient passes away during surgery, no less, that's kind of on him, and because he chose to do that. So that one's kind of a hard one. I feel like I would need more information in it. I'd love to get a doctor's reaction on that, because that was a doctor-doctor interaction, and I'm sure we just on the nursing side, I see specialties go back and forth with each other, just like you will never see cardiac agree with anybody from renal. They butt heads. So that'd be a very interesting take to hear from them.
Who's in? Oh.
What's happening?
Where is that suction coming from?
Don't even know.
Asystole, crash cart, and a chest tray.
Got it. Okay.
Take over compressions.
Scalpels, you're operating here?
There's no electrical activity in the heart, so I can't shock it back.
Are you gonna open it so we can
Internal
do it?
CPR is my only option.
Oh my God. Yep. Oh, please. No one's ever, no.
He's not sterile.
At all.
Hey, Libby.
One out.
How do you, what are we doing in there?
Come on.
What is the thing?
All right.
This is.
We got a rhythm.
Pause.
No,
that would never
that
happen.
was
That's
not.
never gonna happen.
And how did they have the tool to just crack the chest right there? Like, how is it like just
Somebody ran to the OR to get it, I guess.
30 seconds?
We're not doing that. He's not sterile.
We weren't even to the point of needing to do any of that. We could have given meds. We could have shocked him.
We could have
But
given
he
some
had to manually pump his own heart.
like this. There's not enough room.
Baby shark?
There's not enough room to do this. Typically when you see that, they're doing.
I mean, you're sticking your hand in a bowl of noodles and organs are like squishy.
What's happening?
Asystole, crash cart, and a chest tray.
Got it.
Take over compressions.
Scalpels, you're operating here?
There's no electrical activity in the heart, so I can't shock it back. Internal CPR is my only option.
Oh my God.
Got the retractor.
Ambu.
One out.
Come on. All right, we've got a rhythm. He's back. He's back.
Okay, well, I definitely have never seen that happen before. I think CPR probably would have been the way that this situation would have continued to go. I have seen, there's certain things, like a patient just had like a fresh open heart surgery. There's different ways you can do CPR. I know doctors have done that. I think that'd be more of a big surgery thing. But again, that's just me being inexperienced in that area. I don't know for sure. I definitely think that's very dangerous to do, and let alone with the family right there too. That's very traumatizing for the family. So most likely somebody would have removed them from the room to do that. Again, that would have needed to be a sterile procedure because you were opening them up essentially like surgery at the bedside. And so you think about how when we do surgery, we are making sure that everything's sterile, everything's clean, so that we reduce the risk of infection. And again, this patient now is probably going to end up with some other infection due to, him cutting him and opening his chest right at the bedside.
What would you say to someone who's interested in healthcare?
I would say make sure you have a passion for people. You have to have a certain level of caring for the people to want to treat them, to want to learn, and to want to do better.
What would you say to someone who's interested in healthcare?
So I was actually thinking about this on my way to work today, that I am the one out of my peers that loves my job. By getting this degree, by having my nursing degree, I get to wake up every day and be a part of somebody else's life and impact them in such a cool way.
And I think that there's so many different aspects of healthcare. So even if a 12-hour shift on the floor taking care of 7 or 8 patients isn't your jam, there's always something for somebody.
Look at us now, we're teaching.
We're teaching. There are nursing positions where you can work from home. You can work in a Fortune 500 company as an occupational health nurse, or you can get down and dirty in the ER.
But like working in healthcare, you really get to make a difference.
Thanks for watching. A big thank you to Shelby, Tessa, and Megan for joining us today and sharing their expertise. Nurses make a big difference in our lives, and nursing is in high demand right now. Being a nurse, you can make about $60,000 starting out, and it can definitely go up from there. And if you want to learn more about nursing, check out your local technical college. If you enjoyed this video, make sure to like and comment. YouTube Analytics says only 1% of you are subscribed right now, so make sure to hit that button, and we'll see you next time.